Okay, sorry guys. So college is an environment that tends to perpetuate eating disordered behaviors. From individual, it's a stress-induced environment in the sense that college students are leaving home for the first time in their lives. They are responsible for what they eat, when they eat, how often they eat. There's a ton of new food choices, and often on-campus options are not necessarily the highest quality in terms of nutrient density. So students may not have be educated about what kinds of options to select. There's an increased workload, so increased stress in terms of managing time, managing work, as in, being in a lot of our students work, and so they have school, they have a workload, and then they have their academics, a new social environment, trying to make new friends, they're away from home. All of these factors increase, as you all know, for our counselors in the room, the amount of stress our students are under. So it's an environment that is highly encouraging, unfortunately, of behaviors that might end up being problematic in terms of eating habits. A lot of students fear the freshman 15. They've heard that you go to college and you gain a lot of weight, and so they come in already, if that is a fear or concern, they come in already preoccupied with weight and what their body looks like. All right, so let's look at some of the risk factors. Who might be at risk for an eating disorder more so than someone else? I mentioned that anyone who is in close contact with someone else who has an eating disorder, whether it's a sibling, a parent, another family member, they are at increased risk. Anyone who also has a relative with a mental health condition. So I'll talk a little bit in a few minutes about comorbidity among those who have eating disorders. So we see that anxiety and depression are often present alongside eating disordered behavior. Any sort of history of dieting, which is, I guess, could be considered our entire culture, right? We are inundated with messages all the time about diet culture, about how much, what we should look like, what we should weigh, what diet methods work better than others. For example, the one that comes to mind immediately is intermittent fasting. In and of itself, that's restricting or withholding food during a certain time frame, which is not to say that that type of eating can't be helpful in some cases, but it does warrant caution in terms of who is being encouraged to restrict. So anyone that is burning off more than they're consuming, so a constant negative energy balance, so that means you're burning off more calories than you are consuming. College athletes are at a great risk for eating disorders, both men and women, but more so women and female athletes who are under a certain amount of pressure to perform a certain way. We see much higher rates of eating disorders. Anyone with type 1 diabetes, so of course that's where your pancreas stops producing insulin, but we found that 1/4 of women who are diagnosed with type 1 diabetes may have an eating disorder in the future. So that's certainly, that finding is pretty recent. So those are biological things to look at. Psychological. There is a certain personality type that may be at a higher risk. So anyone, we've heard the term perfectionism, one of the common denominators that we see that with a lot of people who are diagnosed with an eating disorder is unrealistically high expectations of performance. So it's not necessarily competing with others, but it's having unrealistic expectations of what you're expecting from yourself. Body image dissatisfaction is a huge piece of this puzzle. So how you feel about your body, how you feel in your body. We'll talk about social media and some of the factors that perpetuate this idea. It's such a pervasive problem in our culture, and one that we really can't get away from. We can't get away from social media unless you don't sign up. So this is not an issue that is going to go away anytime soon. Certainly a prior history of anxiety. I'll talk about anxiety and depression in a little bit, but research does show that there is a significant group of people who experience eating disorders who also have a history of anxiety or depression. Behavioral inflexibility. This is anyone who has a hard time being flexible with their ideas of the right way to do something. And so I talked a little bit about diet culture, but in a culture that is constantly suggesting ways of eating, we get in a very rigid mindset of what you can and can't eat. So food and diet rules perpetuate this behavioral inflexibility. So thinking that certain foods are good, certain foods are bad. This is how you lose weight. This is better than, keto is better than intermittent fasting, better than low fat foods, etc. So we live in a culture that is perpetuating conflicting diet myths that give us that no one knows what is correct. And so we end up combining all of those ideas and thoughts and rules into, it's hard to delineate between some of those things. So behavioral inflexibility, many people, rules make them feel better. And so they get into a habit of depending on those rules for safety. All right, some social factors. We talked about weight stigma. So thinner is better. Thinner makes you a better person. It makes you more, have a stronger willpower. All of those kinds of things. We think in our culture, there's a stigma that anyone who is thin is better, thin is beautiful, thin is smart, etc. Teasing or bullying. One of the most common triggers for the beginning of an eating disorder in early adolescence is bullying and teasing. So if someone is bullied because of their weight, and that's become a traumatic experience, it can sometimes trigger disordered eating habits. Talking about the ideal appearance. So buying into the message that what culture is selling us is actually feasible. We'll talk in a little bit about the fact that cultural pictures that we are being bombarded with isn't reality. So the individuals in advertisements and on billboards, they don't look like that either, right? So there's a social construction as to how we have created this ideal image of what we're supposed to look like that even the individuals in that circumstance don't look like. Social networks. So we talked a little bit about coming to college, and that you're in a new environment and you may not know a lot of people. So individuals who are socially isolated can sometimes be at risk for an eating disorder because they have fewer friends and less social support in those settings. And certainly trauma is also a major factor. So that goes any sort of domestic situation that might cause relational trauma, emotional abuse, verbal abuse, physical abuse. We certainly see that with younger children. The focus of this lecture is mainly college students, but anyone who is diagnosed at a young age, there's a connection sometimes with trauma. So not a factor that we should be overlooking. So what's the difference between disordered eating and actually being diagnosed with an eating disorder? Disordered eating, like I mentioned, is normalized in culture. Everywhere we go, there are messages of what we should or shouldn't do, what we should eat, what we shouldn't eat, when we should eat, how we should eat, what will make us thin, how much we should exercise, cardio is bad, we should we should do HIIT workouts. So this is normative. Everyone is used to hearing dieting messages, what we can do to look better. So some examples of the majority of women, by the time they reach college, I think it's 90% have engaged in some sort of disordered eating behavior. That may be skipping meals. It may be some sort of compensatory behavior, using laxatives or self-induced vomiting. It can be, and that doesn't necessarily in and of itself create an eating disorder, but they're individuals and particularly women, by the time that they reach college, have experimented with how to use some of these tactics to lose weight. So when do we worry? When do we worry if we see someone maybe skipping a meal or two, someone has lost a little bit of weight, someone's exercising a lot? When do we know that we should be concerned about this, our friends, our family members, etc.? The first thing you want to look for is a pattern of behavior. So is this something that you've seen happen one time, or is it something that is happening very frequently? So you go to, you have a friend in your classes, etc., and you never see them eat. If you never see them eat, or they always avoid being in situations where there's food, that's a pattern. Is there preoccupation with food? So are they talking about their body a lot? Are they talking about, that will make them, something will make them fat, something will make them gain weight, etc. So preoccupation, you'll see in a lot of our diagnostic criteria, the fear of gaining weight is a hallmark of those diagnoses. So the fear of gaining 1, 2, 3 pounds, etc., is very critical to the diagnostic criteria. And is there an impairment? So is the pattern of behavior to a degree that someone is being physically impaired, so losing quite a bit of weight? Are they skipping classes? Are they unable to concentrate? Are they fainting? Are they dizzy? Etc. Are their grades suffering? Are their social relationships suffering? So impairment can mean a lot of things, from physical to social, etc. But is there are there negative consequences as a result of the behaviors that you see? I think that the reason I included this graph is because eating disorders exist on a continuum of sorts. It's very rare that someone with bulimia has not experienced or experimented with skipping meals and restricting food. It's common that someone who's been diagnosed with anorexia hasn't experimented with compensatory behaviors like self-induced vomiting or overexercise. So you see a lot of the behaviors in and of themselves are more classic to certain diagnoses, but they're on a continuum of restricting and self-starvation at the anorexia end, and then compulsive overeating for binge eaters. So, but just as a point, there's a lot of variation and similar, but variation of symptoms among all the So eating disorders are a combination of psychological, biological, so we've talked about those factors, and socio-cultural influences. And we just went through some of those things. Just to give you an idea of what a clinical diagnosis looks like. And the reason a clinical diagnosis is important as we get to treatment, in order to get insurance coverage for any sort of diagnosis, to get treatment, you have to have someone clinically diagnose you with one of these disorders. We've come a long way in terms of getting insurance to insurance companies to see eating disorders as a prevailing issue. But the age of onset with anorexia tends to be early adolescence. So early middle school, anyone with classic anorexic signs tends to be younger at the age of onset. It is a severe restriction of calories. So in its truest form, this is lack of food intake. So skipping meals, avoiding social situations. There's an intense fear of gaining weight, even though someone is underweight. So the classic, if you think of someone with an eating disorder, what you may think of as someone with anorexia that's very, very thin, for someone of similar height, weight, gender, age, etc. There is a significant body image disturbance. So there's an over evaluation that is connecting who they are to what they look like. Okay, so it's I am, they're basing their identity and their self-worth on how much they weigh and what the scale says. So certainly there are, and we'll talk about some of the health impacts of eating disorders, electrolyte imbalance, cardiovascular symptoms, those kinds of things can get very serious very quickly for someone who is underweight for a long period of time. Bulimia. The age of onset for bulimia tends to be later adolescence. So later high school, early college tends to be when these behaviors become more extreme to the point of actually having a diagnosis. So to be diagnosed with bulimia, there have to be recurring episodes of binge eating followed by some sort of other behavior. I talked a little bit about self-induced vomiting, overuse of laxatives, overexercise. So someone's eating a large amount in a short period of time. Then after that happens, they are attempting in some way to get rid of those calories in that food. So there's a recurrent kind of opposite compensatory behavior that is trying to prevent weight gain. To have a diagnosis for this, these episodes have to occur at least once a week for 3 months. So we talked about, is there a pattern? How often is this happening? Just like with anorexia, there's a self-evaluation. So how you define yourself, how you see yourself, is very connected to your shape, your weight, your body size. As opposed to anorexia, a lot of individuals with bulimia are not overweight, are not underweight. So even when we talk about the number of men and women struggling with bulimia or binge eating disorder, it's much harder to see. So there's an underdiagnosis with bulimia because it's not as obvious. And people, friends, family members, et cetera, don't necessarily come and intervene as often because it can be hidden in a more, it's not as obvious to those individuals around you. So the person that is suffering with that disorder can hide much easier. All right, binge eating disorder is actually the most common. It was added to the DSM, or the Diagnostic and Statistical Manual, only as recently as 2013. Although this is most common, it's the newest diagnosis. It's recurring episodes of binge eating. So again, it's looking at the kind of the same pattern as bulimia, but it doesn't have the compensatory behavior of getting rid of the food or over-exercising. So eating much more rapidly than normal and really high quantities. But there's marked distress, so feeling the way that you feel after a binge eating episode is impactful in some way. It's negatively impacting someone's life. Either they're not, engaging, they're not as productive at work, they're not emotionally connecting in significant relationships with their families, with their friends, etc. Again, the time frame here is it occurs at least once a week for 3 months. There's a category, there are several other diagnoses that are typical of children and may occur mostly in children, but the category that it's kind of the one where if you don't fall into one of the classic anorexia or bulimia categories, you fall into, it's called otherwise specified feeding or eating disorder. DSM, it was the not otherwise specified category. And this is just where you see some atypical signs and symptoms. There is a misconception that this is not as serious as anorexia or bulimia, which is completely untrue. So the behaviors, these signs, the symptoms, the health impacts are just as severe as any of the other categories. So those are just some examples of what this can look like. So with bulimia, it may be, it's just a little more infrequent, or maybe it happens 2 or 3 times one week and it doesn't happen the next week. So it's just semantics in terms of how you're diagnosing. So some of the things, there's an atypical anorexia, but someone is anorexic but within normal weight range. So that puts them in this category. But just, I did want to emphasize that this is the consequences of being in the kind of catch-all category are just as severe as the other categories. So anorexia, bulimia, and I mentioned a few times the idea of comorbidity, so co-occurring disorders. We know that in college, anxiety and depression are at an all-time high. Coming out of COVID, our students are presenting with those symptoms very specifically. But we do see that there is a common thread, and a lot of individuals who have been diagnosed with depression also have an eating disorder, the same with anxiety. So just to give you some numbers, 32 to 39% of individuals with anorexia also have been diagnosed with depression. About, I would say 36 to 50% of those with bulimia, and 33% of individuals with binge eating disorder have also been diagnosed with depression. Anxiety is a little bit higher, and I'll talk a little bit about that and some of the neurochemical reasons this may be true, but 54 to 81% of individuals with bulimia have also been diagnosed with anxiety, and I'll round it, say 60% of individuals with binge eating disorder have also been treated for anxiety. This is very common. So some of the physiological contributors. We've come a long way with eating disorder research. We have, when we started in this field, I would say in the 70s, people thought it was people acting strangely, right? It was weird behavior. And now, and I would say even in the last 10 years, we're looking at hormones, neurotransmitters, kind of some of the other, when we look at other addictions, some of the biological markers that can trigger addiction, we're looking to see how they relate to eating disorders. We know that serotonin and dopamine are hugely impactful when we talk about eating disorders. So serotonin is the neurotransmitter that shuts off our appetite. It's related to mood, related to sleep, related to anxiety. So those with anorexia have been found to have a naturally high amount of serotonin. That means that they are anxious as a baseline. So the thought behind this is that individuals with anorexia actually feel better in some cases when they restrict because their serotonin drops. So on a baseline level, again, it's just been found that individuals with anorexia have a higher serotonin level. Those with bulimia, their serotonin tends to fluctuate more extremely, which can lead to both binging and impulsive behavior. With binge eating disorder, it is shown that serotonin is chronically low. That's why binging episodes decrease anxiety. So they're trying to raise serotonin levels by binge eating. For dopamine, dopamine is the pleasure neurotransmitter. It makes us feel better. The research here is a little more mixed. They were trying to figure out what it's not as specific or what I should say consistent as some of the research on serotonin. We have found that dopamine levels also tend to be elevated in those who are anorexic. So dopamine, there's the idea of anorexics tend to be, they restrict so they can feel. So at a baseline, they have a limited ability to increase or feel their pleasure response. So dopamine tends to be higher in individuals with anorexia, tends to be lower with those, dopamine tends to be lower with individuals with bulimia. So I'll talk about sugar here in a second, but we know culturally that sugar creates a high, right? Which is typically short-lived, but our brain lights up whenever we feed it sugar. So bulimics feel better when they are eating foods that are high in fat, high in calories, high in sugar. And the general thinking is that increases their dopamine and they get a pleasure response from binging. The same is true, the same general theory is true for binge eating disorder, and that as individuals who are binging, they get an excessive release of dopamine. So binging on high sugar, high fat foods makes them feel better. So I hope my reason for putting some of these psychophysiological, biological rationale in here is because I think a lot of individuals feel like they can just stop. They don't understand why it may be happening to them, why they may be more susceptible. This is also a reason to get help. So there are biological susceptibilities that an individual may have, and if they get treatment, they can get control or stop some of those behaviors. So there's a biological foundation that has been overlooked for a long time that I think has taken some of the stigma away from eating disordered behavior. Again, I mentioned that both bulimia and binge eating disorder are underdiagnosed. I think there's a guilt and a shame that is associated with some of those behaviors. And a lot of individuals just don't know that there are some biological reasons that they may be more susceptible to falling into some of those behaviors that are harmful. Hormones, so neurotransmitters, our hormones also send signals throughout our body. So both leptin and ghrelin, those they shut off our hunger mechanisms. And there is truth that when we are not eating, if our body is hungry, if we're not giving ourselves the nutrients that we need, then these are going to be disrupted. So leptin is basically the hormone that tells us to stop eating. For anorexics, leptin levels tend to be lower, which allows them to restrict for long periods of time. So those hormones aren't operating in normal capacity. With bulimia, they tend to be moderately low. So if leptin is low, you're going to not be as full. So it might signal a binge. With binge eating disorder, leptin levels are typically higher. which is signaling to the body to eat. So our hormones have a lot to do with telling us that we should be eating, both leptin and ghrelin. And ghrelin triggers hunger. It tends to be higher in individuals with anorexia, which is counterintuitive in the sense that you would think that someone with anorexia, if they had high ghrelin, that they would eat a lot. It tends to have the opposite effect with anorexia. So a high level of this hormone actually tends to shut off some of those hunger cues. All right. So again, some of those physiological contributors are important to note because they're part of the way that we can fix and treat eating disorders if we're looking at some of the recurrent behind some of the symptoms and behaviors. So what does it look like? What should we be noticing? What do you see as a friend, a family member, a health practitioner, what to look for in someone who might have an eating disorder? So these are physical signs and symptoms. Certainly rapid weight fluctuations. So either gaining weight or losing weight in a really short period of time. You lose or gain weight, typically more so when you're losing weight, a lot of weight in a short period of time. Fatigue and fainting is very common. So being lightheaded, being dizzy, your electrolytes are off. And so those can cause low energy. Interrupted sleep. So I mentioned that serotonin helps with our sleep. It's a precursor to melatonin, which is the sleep hormone or neurotransmitter. And so interrupted sleep is a very classic and common sign. Waking up hungry. If you don't provide your body with enough nutrients, you're not going to be able to sleep as well. Certainly GI discomfort. So not eating enough food means your body doesn't have what it needs. And there's a lot of GI discomfort for anyone with bulimia or binge eating disorder. So overtaxing the body, certainly with bulimia, there's a lot of esophageal issues and bloating that can come about from some of those behaviors. Dry hands, hair loss, poor circulation. So if someone has lost a lot of weight, they're cold all the time. Talked about hair loss. A very classic sign of advanced anorexia is lanugo, which is that very fine hair that grows all over the body in an attempt really to provide, keep the body warm, right? Your body just develops that fine hair as a layer of insulation. Chest pain, heart palpitations. I'll talk a little bit about this when I talk about some of the circulatory consequences of eating disorders. But with a drastic fluctuations in our electrolytes, that can cause arrhythmia, cardiac arrhythmia. Certainly for women who have lost a significant amount of weight, it disrupts the menses. So amenorrhea is a very classic sign. What does this look like? So that was physical signs. What might someone look like? And some of the physical criteria. For behavioral signs, dieting, chronic dieting, extreme dieting, chaotic food intake. So if you're looking at someone who has to have food now at a certain time, you see them eating a lot of food or binging, eating a lot of food in a short period of time. I talked a little bit about preoccupation with food. So looking at what other people are eating, but they don't want to indulge, saying things like, oh, well, I had dessert last week. Just any sort of preoccupation with food. It's very common to hear things like, well, that will make me fat. I'm so fat. Comments about their size and shape, or comments about how great someone else looks. Okay, so it's an inaccurate comparison or evaluation, not only of themselves, but of other people. Going to the bathroom could be signs of self-induced vomiting, overuse of laxatives. If you're a roommate with someone with an eating disorder, you might notice things like that. Change in clothing style, so an effort to hide weight loss, or in binge eating disorder if someone has gained a lot of weight. Eating in isolation, I talked about that a lot. So not eating in social settings, but only eating their own food in their own way by themselves, being overly controlling of their an eating environment. All right, so emotional symptoms. I talked about fear of gaining weight being a very classic sign of an eating disorder. And again, that's because their weight is tied to their worth, right? They are basing their identity and their worth as an individual to how much they weigh. Severe mood swings are also common. So serotonin impacts our mood. If there are fluctuations in our serotonin and our dopamine, we're going to see that with mood swings. So someone being really happy, maybe when they've lost weight, or overly upset or anxious when they've gained weight. I talked about withdrawal from social situations, so not being around friends, skipping activities, wanting to be alone, having excuses for not going to do things that they would normally do. Low self-esteem, perfectionistic tendencies. So there's a certain mindset to someone with an eating disorder. An example with bulimia is that if they can't, maybe they have a certain way that they want to eat in a day. And if they eat 2 crackers over what they think that they should be eating, that might perpetuate some sort of binging cycle. So there's a very extreme thought process that goes along with eating disorders that wouldn't make sense to an average person thinking, well, you ate 2 more crackers. But to them, 2 more crackers might signal, 2 more pounds, or it might mean they're terrified that they're going to gain weight or that they've failed. So they haven't been absolutely perfect in what they wanted to do for that day regarding their food intake. So perfectionism is a hallmark tendency. Feelings of worthlessness, that kind of went in with the mood swings. And then increased signs of depression and anxiety. Some of the health impacts. Why is this important? Why are eating disorders the deadliest mental illness aside from opioid use? Why is this such an issue? We'll talk about some of these things, and then I'll circle back to why this is so important. So cardiovascular symptoms. The risk of heart failure rises as heart rate and blood pressure levels are lower. So individuals that are underweight tend to have a lower blood pressure. That is not necessarily a good thing, having a chronically low blood pressure. It can actually be very problematic and put you at risk for cardiac arrhythmia or having a heart attack. If you're malnourished, malnourishment significantly impacts our muscles, right? We break down our muscles for nutrients. The heart is a major muscle. So it weakens our heart long-term to be underweight, malnourished. And that's one of the major causes of cardiovascular symptoms. And the other one is electrolyte imbalance. So potassium regulates our heartbeat. If we're losing fluid, so this is very common with bulimia. If you're losing a lot of fluid through self-induced vomiting or laxative overuse, you will end up getting cardiac arrhythmia. So that's from potassium, regulates our heart rate. Sodium and chloride, again, become imbalanced after purging, and that can cause irregular heartbeat. And I think cardiac symptoms and irregular heartbeat is the most common cause of death among those with bulimia. So heart issues are very common. GI issues. So when you're dealing with your GI tract, which is eating, and what does our GI system do? It takes food and it makes them useful to our bodies, makes it useful to our bodies. So stomach pain and bloating, nausea and vomiting, blood sugar fluctuations. So it's very common in the case of bulimia and in the case of binge eating disorders for there to be very, very extreme blood sugar fluctuations because insulin is having to overreact to counterbalance binging. So blood sugar, you can get dizzy. Say if you binge a lot and then you purge, that can make your blood sugar fluctuate quite extremely and make you dizzy, etc. Blocked intestines, bacterial infections, weakening of the esophagus. Those are some of the things that can happen with self-induced vomiting and overuse of laxatives or other behaviors that eliminate food. People are trying to, again, in an effort to maintain their weight. Neurological impacts. Brain. If you're malnourished, undernourished, and so when I talk about malnourishment, it's not just the macronutrients, so fat, protein, and carbs. Individuals with eating disorders are, I would say 95% of the time, malnourished in terms of micronutrients. They don't have vitamins and minerals, and in some cases that's more important because those are the bases for all of for proper functioning of our body, our heart, our brain, etc. But certainly, when our brain doesn't get enough nutrients, we see an inability to focus. So that's a classic sign of an eating disorder, is just the inability to concentrate, not being able to sit down and complete a task. Talked a little bit about sleep disturbances. So if you're not eating enough, you're waking up hungry, your body doesn't have what it needs to recover and process those nutrients throughout the night. So difficulty falling asleep or staying asleep is very common. Let me see what else I want to talk about. We talked a little bit about electrolytes, that our neurons use electrolytes to send impulses. So for our nervous system, we need those electrolytes to be balanced. So dehydration and electrolyte imbalances can lead to seizures. Muscle cramps is a smaller symptom, but seizures can happen if those electrolytes are imbalanced for a longer period of time. All right. So the endocrine system, so our hormones, certainly for our sex hormones, estrogen and testosterone, you have to have fat to build those hormones. A lot of people with eating disorders are afraid of fat. Why? That will make you fat, right? There's a fallacy there that we store fat as fat, which is not how our body uses it. But again, some of those misconceptions get stuck in our brain and we can't let go of those. Eating fat does not make you fat. That fat is triglycerides, cholesterol. They're hugely important for our hormones to function properly and well. Not only the sex hormones, but the thyroid. One of the, I would say, more classic signs of someone who's been anorexia for a long period of time is that they develop osteoporosis at a younger age because their bones are brittle and weak. All right, let's see. Talked about hair, skin and hair is dry and falls out. Dehydration can lead to kidney failure. So again, the balance of those electrolytes also affects your kidneys. It is very, very, very common for individuals with an eating disorder, namely anorexia or bulimia, to have anemia. So it affects our blood pretty significantly. The inability to store iron. The main way we get iron is we absorb it through the foods that we eat. So we can also develop too few red blood cells and a decreased number of white blood cells. So we know that our white blood cells make us more, the more we have, the better we can fight off infection, right? So if we have a lowered number of white blood cells, our immune system is compromised, right? Where we see a lot of illness. Individuals with eating disorders are more likely to get sick because they have a decreased number of white blood cells. Those are what eating disorders are, sometimes what it looks like, who's at risk. One of the things that we have talked a little bit and I've referred to is body image. You can't separate an eating disorder from body image, right? This is the psychological component of an eating disorder. Body image is how we think about our physical appearance. So it's our thoughts, our perceptions, our attitudes about ourselves, and then tying them to who we are. So body image and how we identify ourselves. So how do we feel about our bodies? What is a positive body image? I think we know what a negative body image is, but what does a positive body image look like? There's a true perception, meaning a realistic perception of our shape and seeing our body as it is, but not connecting that to our self-worth. So positive body image, I would call it more a realistic picture of what we look like in comparison to others. But again, it doesn't drive our identity. So having body positivity involves feeling comfortable and confident in who we are, despite what we look like, despite how much we weigh, despite whether we've lost a certain amount of weight here or there. So negative body image. When someone has a negative body image, they have a distorted perception. So again, positive body image is a realistic perception. A negative body image is a distorted perception of our shape. There is a condition called body dysmorphic disorder, and it's someone who's 100 pounds. You ask them to draw a picture of themselves, and they'll draw a picture of a 200-pound person, right? So it's the inability to really see yourself for what you look like in that register. So a distorted perception of one's shape that involves shame, anxiety, and self-consciousness. So it's an over-assessment of your body and what you look like and tying that to your identity. We'll talk about the media in just a second and how media perpetuates the idea of looking a certain way, and that can increase a negative body image. Okay, how do we prevent eating disorders? I could talk about the nutrition side of this for a long time, but I won't. But I mentioned that diet culture is rampant. It's everywhere, and we're constantly getting mixed signals. The term diet actually means what do you eat every day? But just the connotation that we have with the word diet, going on a diet, going on this diet, going on that diet, from Weight Watchers to, diets are everywhere. Diet theory is everywhere. And the idea is, how can I lose a lot of weight in a short period of time? For men, sometimes it's how can I gain weight? How can I lose fat, gain muscle to look a certain way? So and I'll show you in the next slide, how sugar can perpetuate anxiety. But whole food nutrition is really important. What is a whole food? It's a food that has not been processed. It doesn't come in a box. It doesn't come in a package with ingredients that you don't know how to say, right? So celery is celery, an apple is an apple, chicken, beef, etc. It hasn't been processed to the point where things are added into it. But it is whole foods give us the nutrition that we need. So produce, lean meats, dairy, nuts, seeds, etc. So we can enjoy any and every food. Diet culture tells us that there are good and bad foods, that there are foods that make you fat, foods that make you, no food in and of itself makes you fat. Just the bottom line. There's room for everything, but focusing on whole foods, mainly because they also give you the most nutrients, the most fats, carbs, and proteins, but also the highest micronutrient content. So all of your fat soluble vitamins like A, D, E, and K, which all are those fat soluble vitamins are the basis for all of our hormones. So whole food nutrition, I would focus on eating foods that make us feel better. There are certainly foods that we can eat that make us more anxious or more depressed. We'll talk about that in just a second. Say pushing against the idea that diet, weight, or body size will make us happy. I think this is, in terms of prevention, this starts very, very young. These cultural messages are so pervasive that unless we teach children how to evaluate themselves differently, it's not going to get any better. So the prevention side of eating disorders can be very, very challenging. I think it starts with whole food nutrition and teaching kids where food comes from and how to eat. Prevention, I think learning what you can about eating disorders and what they look like. So knowing what can happen, you can work backwards to create an awareness for how food ideals change our behavior over time. So awareness can help you help other people. Making the choice, so challenging cultural ideas. Again, this is hard, much more difficult than just saying go against what culture says. But the idea that thinness and weight loss are attached to our character is hopefully will be outdated. But if the media has anything to say about it, it won't. But I do think that we understand eating disorders a little bit better, certainly better than we did 10, 15, 20 years ago. But this is just a graph that kind of shows you how sugar, so sugar meaning really simplified carbs, processed foods, how they can impact our anxiety level. Okay, so this isn't referring to eating disorders specifically, but what we eat is very directly linked to how we feel. So sometimes we feel anxious. What happens if we feel anxious about a test or a relationship? Maybe you go eat ice cream, you go have a dessert, etc. Any type of sugar or refined carb. When we eat it, we have a sugar rush. We have a sugar rush because the body has nothing it goes directly to our bloodstream. There's nothing to break down. With whole foods, the more fiber is in our foods, digestion happens much more slowly. So we don't have a sugar rush. The glucose in that food is distributed to our bloodstream over time. So we don't have a sugar high. But after you have a sugar rush, you digest that sugar and then you crash. So I have several young children. You can see a sugar crash very noticeably among children because you see it in their behavior. Well, the same happens for us. It just doesn't look like a temper tantrum for a toddler, but our mood is affected just as severely when we consume sugar consistently. So this is just an example of whole food nutrition, what that looks like, and things that we can do to decrease our anxiety levels. Okay, other prevention methods. Stop evaluating others by how much they weigh, right? So it's eliminating weight and body shape as the way that we interact and see people. I'll talk about this in just a second. Becoming a critical viewer of the media. So I think it's an awareness that the media has an agenda and that we are, of course, it's targets, but we are susceptible to buying into their messages. Valuing ourselves based on what we can do and who we are and not what we look like. And certainly part of prevention is getting help as soon as we can. So early intervention is also prevention. So talking to someone, expressing your concerns that you might have for yourself or someone else. We'll talk about that in just a second. Okay, let's look at the media. 80% of Americans watch television daily, over 3 hours a day. This is the concerning number to me. On a typical day, 8 to 18-year-olds are engaged with some form of media for 7.5 hours. There's only 24 hours in a day, right? So for 7, they're exposed to so much media. Certainly smartphones and being able to access media at all times of the day has contributed to that number increasing so drastically. But that means we are always plugged into media, always. Music, television, it's just bombarding. Of course, social media, this is not specific to social media. But of course, that may be where the 7.5 hours comes from. So this is an old study, so I can't imagine how this number would be changing and how would it increase to today. But weight loss advertising found that half of all advertising for weight loss products made use of false substantiated claims. So the hallmark of weight loss is the testimonial, right? So this is what it did for me. This is what it can do for you. Well, those people are being paid to say that. So just being privy to some of the ways that the media is trying to sell you an idea, sell you a product, make you buy into a thought process, just creating an awareness of that is really important to critically evaluating media messages. So always think about who's paying for my attention. So what are they trying to sell me? So it's being a skeptic when you're looking at media. So both correlational and experimental studies have linked exposure to the thin ideal, right? The thin ideal is the socially constructed thin person on magazine covers, on Instagram feeds, on etc. So the exposure to the ideal has increased everyone else's body dissatisfaction and what people should look like. So I have seen more recently how on Instagram specifically, Instagram, TikTok, someone will post a picture that's posed and then they'll post what their real body looks like. So I think that there's a growing awareness that the messages that we're receiving are constructed, right? They're very, very rarely a true picture of reality. Of American elementary school girls who read magazines, 69% say that the pictures influence their concept of the ideal body shape. 47% say the pictures make them want to lose weight. These messages are hitting young females and males earlier and earlier and earlier. The average age of onset for anorexia specifically used to be like 14. I think that that's now down to 12, 13. But I mentioned that the majority of women, by the time they do get to college, have experimented with disordered eating behaviors. So they've attempted to lose weight in an unhealthy way in some way. An 8-year-old, in my opinion, should not be worried about their body. This was as of 2010. So I know that there are statistics, not just looking at magazines, but now looking at social media. So what do those images perpetuate? What is that ideal? That ideal is socially constructed. It isn't real in and of itself. Okay. The same is true for men. So the perpetuation of lean, muscular, built body for men. So there's a constructed opposing, or not necessarily opposing, but picture for men just as much as there is for women. So how do we view the media critically? So what lens do we view media messages through? They're all constructions. They're not reality. So they are not a reflection. Those individuals in and of themselves don't look like those pictures. So advertisements and other messages have been carefully crafted, and are intended to send a very specific message. Advertisements are trying to convince you to buy or support their product. They're selling you something. They're always selling you something. Advertisers create their messages based on what they think you want to see. So marketing research goes in and says, what do people want to see? This is what they want to see. This is what we're going to give them, right? So they're tricky in the sense that they're perpetuating the idea based on what they think that you want to begin with. As individuals, we get to decide how we experience media messages. We choose the filter through which we see them and how those messages apply to us. So we can value ourselves through the lens of those media messages or apart from it. Some more practical ways to do this. First, it would be easy probably to say don't view those messages, but don't follow things that don't make you feel good, right? So either unfollowing or eliminating sources of the media that make you feel a certain way that's negative. So choose the media that you consume mindfully, limiting screen time, not being on in a media outlet for 7.5 hours a day. Testing the message for body positivity. So looking at that message and saying, does that make me feel better? Do I feel better after looking at it? Or do I feel like I need something else, to buy something else, to change the way I look, to be a better person? Have conversations with people around you about social media, about body image, about how unrealistic some of the expectations and the messages are. Advocating for positive body talk. So all of those are ways to kind of change the way that we consume media. Okay, and again, all of those media sources lead us to think that there's something wrong with us. So they plant a seed of dissatisfaction with ourselves. Treatment, eating disorder treatment. If you are someone who recognizes some of these behaviors in yourself, even if you're not to the point of having a diagnosis of an eating disorder, that's even better. Go talk to someone if you're engaging in behaviors around food that might be problematic in the long run. So telling someone you trust, a parent, a friend, a teacher, talking to someone is really important. If you do seek help at the counseling center or from someone else, just if you get it, you don't necessarily have to get a diagnosis, but seeking help initially is really the first step. So typically eating disorder treatment, you have to address both the psychological component and the biological component. So you have to address the negative and unrealistic thought processes that happen. And then certainly you have to address the food side, right? So making sure that someone is getting their nutritional needs met. So one of the complications of eating disorders is that it's been studied alongside addiction research because the behaviors become addictive in and of themselves. I was in a seminar one time and heard one of the reasons eating disorder treatment is so difficult is that it's like trying to teach an alcoholic how to moderate alcohol, right? So with a lot of other substance abuse, whether it's alcohol or drugs, abstinence is typically the method of treatment that we use. So moderation is very, very hard to teach. And so that can be difficult and tricky when it comes to treating eating disorders. So certainly, again, we have to treat the psychological side and the physical side. Certainly, if the eating disorder has progressed to a certain point, there has to be an assessment of what has happened physiologically. Again, so I talked about, some cardiovascular symptoms, GI symptoms. If those have reached a certain point, certainly a physician would be brought in to address those things. I talked about nutritional counseling. So most individuals with an eating disorder will meet with a nutritionist. The goal there being to kind of debunk or counteract a lot of the incorrect messaging that someone has received through the media. Again, kind of the idea that fat makes you fat, etc. Depending on the severity of the illness, there are different types of treatment. So intensive outpatient, that means that someone can be, or outpatient treatment, someone is seen, they go about living their daily lives, but they engage and receive help from mental health practitioners and nutritionists. Residential is when someone has reached a point of the illness that they would go into a residential program, kind of like what you might say rehab would be like, but they go to a facility in an effort to rehabilitate their behavior. Again, one of the reasons that we talked about eating disorders cost $58 billion a year. Treatment is very expensive for eating disorders. It typically takes longer than 30 days, right? Which is typically what an insurance company will pay for. So residential treatment is certainly an option and one that if it has reached the point where someone has experienced pretty severe physical consequences and social consequences, it's interrupting their ability to study and work, etc. Someone would enter a residential treatment facility. And then inpatient is when someone needs to be hospitalized because they are significantly malnourished. How do we help? If you know someone, if you have a friend, a family member, a significant other who has an eating disorder, what would you do? First of all, I would encourage you to learn as much as you can. Okay, so go and investigate what the different eating disorders are, what those behaviors and signs and symptoms look like. So take it upon yourself to be educated about what eating disorders are. Rehearse what you want to say. Certainly approach someone out of concern and not out of blame, right? So approaching someone that you're concerned for them, doing it in private. So not confronting someone in a huge group of people, or maybe you're seeing someone, at the cafeteria and you say, "You've lost a lot of weight. Are you anorexic?" And asking those kinds of questions in an environment that would put a spotlight on that individual. So doing it in private, where that conversation can be more serious if you want it to be. No one wants to be confronted about their behavior in a public situation. Being honest. So telling someone why you're concerned, what some of the behaviors you've seen are, using I statements, so focusing on what you have personally observed. Okay, so I've noticed that every time we go eat at lunch, you're not eating. Is everything okay? Right? So those I statements are really important. Again, not attacking someone for what you think might be the problem. Sticking to facts. Okay, so this is a very emotional issue. Like I mentioned, most people with an eating disorder are ashamed of that behavior. There's shame, there's guilt, there's fear. And so the emotions run high. Sticking to the facts about what you've seen, what you know, and what might be helpful. Be caring. You want to be sensitive. Removing stigma. So basically telling that person, there's nothing to be ashamed of. I'm trying to help you. Can help sometimes. Avoiding overly simplistic solutions. So you should just eat lunch. You're not fat, right? You need to gain some weight, or saying things that oversimplify what the issue might be. And certainly trying to connect individuals to resources that you know of. Here, that would certainly be the counseling center, or talking to an adult. And so you should be prepared for negative reactions. No one likes to be confronted about something that they would like to be kept private. So you should expect that someone is going to maybe push back a little bit. And sometimes but in the back of their mind, they may know that you might help them at some other time, or help eventually if they're ready to get help. Certainly encourage them to seek professional help, or to talk to someone about it. Talk to anyone that they feel like is a safe person to talk to. Okay. So those resources on campus, certainly our counseling services here. There are a lot of online resources to educate yourself about eating disorders. There are hotlines, so anonymous hotlines that you can call, that you can talk to a random stranger who would help you get connected with someone in our area that could help you. So those anonymous national hotlines, sometimes it's easier to admit something to someone else than it is, or to someone you don't know, than it is to a friend. And then the ANAD and NEDA were, a lot of my information came from them about the more recent statistics and the breadth of the issue. Are there any questions? Does anybody have a question online? Mm-hmm.
Like this body acceptance movement, where it's okay to accept the body shape and size you are, even though that's an unhealthy sort of way inside.
So there's a counter movement that's kind of saying, instead of thin is beautiful, it's okay to be significantly overweight. Is that what you're alluding to a little bit?
Is that sort of weight?
So I would say it's the same continuum, different sides of the continuum. Because my thought would be, unless that individual has been cleared by a physician, and that's okay for them, I don't see I think that there's a happy medium, which is pretty extreme, right? There's a pretty, there's a normal weight range that I think people can exist comfortably in. It would be my personal opinion that it's basically the equal and opposite reaction on the other end of the continuum that I don't think is any more healthy than the other extreme. Is that what you were asking? How do you address it? Oh, in a specific, I don't know that, I think that's again going to take, critically evaluating media, right? So trying to figure out what message they're sending or what purpose is it solved? Does it make them feel better? Are they trying to sell an idea in some way? For specific patients or specific clients that you see, I think the question is, do you feel good? Do you have the capacity and the energy and the ability to engage in life the way that you want to? And if they do, then I guess that's okay, right? So to me, the definition of health is being able to participate in life the way that you desire. So they're defining it that way. Does that make sense? Did that answer your question?
On one end, we have the idea of
Yeah.
Mhm.
Mhm. Mhm. That's true. And I think what's difficult and sad is that it's the deck is stacked, right? So it's hard to eat whole foods. Like I say that so easily, right? So I say, oh, eat whole foods. And yet I have a family, 3 young kids. It's easier to go through Chick-fil-A, right? And yet there's a lack of prioritization around food as, you are what you eat. And so our culture it's cheaper to eat junk food. It's easier to go through the drive-through. So I think unfortunately, it takes a lot of effort to be healthy. And in a lot of cases, people would rather take some sort of medication than change their behavior, which is a whole nother topic. But yeah, with the cultural predominance of time and, we're busy and we're stressed and people don't prioritize food very well, or cooking or eating at home or eating as, I think just food behaviors in general, it's eating as a family, those kinds of things that have just shifted and changed along with what our food looks like and what's in our food. I don't know if that helped. Anybody else? Do what? I don't think, well, let's see. No, I'm not. Where do I go?
Let's see.
Right.
Any other questions?